This video describes the technique of intravitreal injections. Let's see what all we need to check before injecting. First, go through the patient file. Informed consent should be present. Verify the patient's name, eye, and type of injection. Next, rule out any active infection like conjunctivitis. Remember not to miss blepharitis or mebomitis. Lastly, check the injection and expiry date. Masking is essential for both the patient and the doctor, and talking should be minimized. So, wash your hands, don your sterile gloves, and let's start setting up the sterile field. The sterile towel is unwrapped and placed on the Mayo stand. The instruments needed are sponge holding forceps, cotton gauze and cotton buds, calipers, scissors, speculum, and toothed forceps. We now move on to prepping the patient. Re-verify the eye of the patient before starting routine dressing and draping. 10% povidone iodine solution is applied on the eyelashes, eyelids, and periocular skin. Sterile drapes are next used to cover the patient's face and eye. A sterile speculum is applied to prevent lashes from contaminating the field. Once the sterile field is set, we can start drawing the injection. Two different types of needles are required, an 18 gauge and a 30 gauge needle, which are usually supplied with the injection. In some injections, the 30 gauge needle is not supplied and needs to be taken separately. A 1 ml syringe is also needed. After rechecking the expiration date, the injection box is opened. The injection vial is inspected and opened in a sterile manner. The 18 gauge red color filter needle is used to draw the liquid from the injection vial in a sterile manner. After making the liquid air-free, the 18 gauge needle is discarded and the 30 gauge needle is attached. Intravitreal injections are performed under topical anesthesia, which can be proparacaine drops or proparacaine soaked cotton swabs. Some surgeons prefer to use subconjunctival anesthetic. We are now ready to inject. 5% povidone iodine drops are instilled prior to injection. Calipers are used to measure the distance from the limbus, 3 to 3.5 millimeters in aphex and pseudophax and 3.5 to 4 in phakics. Adjust the dose of injection yourself to the recommended 0.05 ml. The common site of injection is the inferotemporal quadrant. The patient is asked to look in the opposite direction. The needle penetrates the sclera and is advanced towards the center of the globe in a straight path. The solution is injected in the mid-vitreous and the needle gently retracted using a budge to prevent reflux. Instill topical antiseptic before closure. Triamcinolone acetonide is injected in a manner similar to anti-VEGF. The solution is withdrawn from the vial using a sterile technique. Its dose is 2 mg or 4 mg. The only difference is that triamcinolone is injected using a 27 gauge needle because of its crystalline nature. Injecting OZURDEX is a slightly more complicated procedure. The extended release biodegradable dexamethasone implant is preloaded in an applicator which comes within a foil packet. The foil packet is opened and the applicator withdrawn, maintaining sterility. Let's take a look at the parts of the applicator. It has a push-button delivery system with interior lock to prevent backflow or reuse. It has a protective cap and a safety tab to prevent accidental discharge. Topical anesthesia and antisepsis are done after setting up the sterile field. Dab cotton swabs over the site of injection and mark the sclera with calipers at appropriate distance from the limbus. Next, remove the safety tab without twisting or turning it. Remove the cap and inspect the implant, whether it is completely present within the applicator. With the bevel up, penetrate partial thickness sclera while going parallel to the limbus. Once the bevel is buried, turn towards the center and completely insert the cannula. Press the button slowly till the audible click is heard. Now gently retract the needle, placing a bud over the site to prevent reflux. Visualize the implant within the vitreous cavity. After giving any injection, it is essential to examine the fundus to check central retinal artery perfusion. If occlusion is suspected, paracentesis needs to be done. Check if the patient is able to perceive light or counting fingers. A sterile eye patch is then placed and the eye is patched for a few hours. Post-operative instructions should be clearly explained to the patient. Avoid water in the eyes for 3 days. Eye drops are not routinely prescribed. IOP is to be checked every 1 to 2 weeks in patients with OZURDEX. Don't forget to remind them to visit in case of any emergency. Coming to technical variations, injections can be carried out in office settings also. The path of entry of needle can be straight or biplanar tunneled. Tunneled biplanar or stepwise entry path and the use of low gauge needles can cause less reflux. The use of post-injection antibiotics is controversial. It is advised to avoid antibiotics as repeated use can lead to resistance. They also have low vitreous penetrance. Bilateral injections on the same day have been deemed safe, provided that each eye is treated as a separate case. Now, for the expert tip. Most of the patients require repeated and multiple injections. In order to avoid double penetration, change the injection site by 1 clock hour at least. This prevents the development of vitreous incarceration or scleral hole. These are my acknowledgements. Happy injecting.